on urinary elimination. I am going to be using a PowerPoint from the Potter and Perry Chapter 45, which is posted on your CourseDen account. Chapter 45, Urinary Elimination. I know we covered some of this in class, but we're going to go ahead and cover it again. Normal elimination of urinary waste is a function that affects all body systems. Patients with alterations in urinary elimination may suffer emotionally from body image changes. It is important to know the reasons for urinary elimination problems, to find acceptable solutions through the nursing process, and to provide understanding of sensitivity to all patient needs. If you'll go to the second slide, it talks about scientific knowledge base and the organs of urinary elimination. Urinary, and we did talk a little bit about this in class, to go back and make sure that you knew your anatomy and physiology. So it depends on kidneys, ureters, bladder, and urethra. Kidneys remove wastes from the blood to form urine. Ureters transport the urine from the kidneys to the bladder. The bladder holds the urine until the urge to urinate develops, and then the bladder holds the urine until the urge to urinate develops. I just said that, sorry. Urine leaves the body through the urethra. And then all organs of the urinary system must be intact and functional for successful removal of urinary wastes. Intact efferent and afferent nerves, so that's the sensory and the motor side, from the bladder to the spinal cord and brain must also be present. And if you do need to review any of your anatomy and physiology, like I said, you can go back to your A&P textbook, or also to Iggy has a decent review on that. On slide 3 are some pictures of the urinary system. And let's see, don't forget the renal artery that branches off the abdominal aorta. Remember, the nephron is the functional unit, produces the urine. It has the glomerulus, Bowman's capsule, the proximal tubule, the loop of Henle, the distal tubule, and the collecting duct. And then the ureters are the tubes that bring the urinary down from the bladder. And we did talk a little bit about that. Remember that the system is sterile. The ureters enter obliquely through the posterior bladder wall. And so that makes it so that there can't be a reflux of urine from the bladder into the ureters during the act of micturition, which is what we call voiding. An obstruction within a ureter, such as a kidney stone, results in a strong peristaltic wave, and those peristaltic waves are what causes that significant pain that comes with a kidney stone. Sometimes that pain is called renal colic. The urinary bladder, remember, it's hollow. And the organ, this is important to remember, the urinary bladder, the muscular part of the organ is called the detrusor muscle. That's what causes it to contract. And so when it's empty, the bladder lies in the pelvic cavity behind the symphysis pubis. When the bladder is full, it expands and extends up above the symphysis pubis. A very full bladder, like I was talking about in class, may very well reach the level of the umbilicus. Now at the bottom is the trigone, is the small triangular area of the inner surface of the bladder, and it acts as the base, and that's where the opening exists for the urethra. And normally the turbulent flow of urine through the urethra washes it free of bacteria. Mucous membranes line the urethra, and urethral glands secrete mucus into the urethral canal. There are thick layers of smooth muscle that surround the urethra, and so in addition, it descends through a layer of skeletal muscles called the pelvic floor muscles. And when these muscles are contracted, it's possible to prevent the urine flow through the urethra. In women, the urethra is approximately 1.5 to 2.5 inches long. And so because of that short length, then it predisposes women to an increase, and girls to an increase in urinary tract infection. For men, the urethra, it's about 8 inches long. The male urethra has three sections. prostatic, membranous, and penile. So there's a little bit of an anat and phys review for you. On slide number 4, it says, patient with a long-standing history of diabetes mellitus is voicing concerns about kidney disease. The patient asks the nurse where urine is formed in the kidney. What is the nurse's response? A, bladder, B, kidney, C, nephron, D, ureter. The correct answer is C. It is formed in the nephron. On slide number 5, there's a little question of case study. This is Sandy, the nursing student, learns about Mrs. Valero at the 3 p.m. shift report. And if you'll pause right here for a second and then read the case study, then I have a question for you. Great. Now that you're back from reading the case study, if you were the nurse receiving a report, what questions would you have if you were Sandy? Okay, we're going to come back to that. Just remember some additional kidney functions that you learned in anatomy and physiology on slide number 6. Kidneys also produce erythropoietin. They're responsible for maintaining a normal red blood cell volume. Erythropoietin functions within the bone marrow to stimulate red blood cell production and also prolongs the life of the mature red blood cells. So patients with chronic kidney conditions can't produce sufficient quantities of erythropoietin, therefore they are prone to anemia. Another one of the functions of the kidney is the blood pressure regulation. And so renin is released from the juxtaglomerular cells. And we're going to talk about that on the next slide. And then kidneys also affect calcium and phosphate regulation. And they produce the substance that converts into vitamin D in its active form. Patients with chronic renal disease do not make sufficient amounts of active vitamin D, and so they are prone to develop renal bone disease resulting from demineralization of the bone caused by impaired calcium absorption. So we'll talk about that a little bit more when we get to the nutrition section. If you'll look on slide number 7, we're going to talk about the RAA system just a little bit. I know that you studied that this last summer in Pathopharm 1, but I want to make sure that we talk about renin and angiotensin one more time, because we're going to talk about fluid and electrolytes in 2 more weeks. So this has to do a lot with the fluid aspect. Now, renin functions as the enzyme to convert angiotensinogen into angiotensin 1. And angiotensin 1 is converted into angiotensin 2 in the lungs. So the kidney, the liver, so angiotensinogen is synthesized in the liver, renin in the kidneys, and then they have to, they work together to be converted from angiotensin 1 into angiotensin 2 in the lungs. And angiotensin 2 is a very powerful vasoconstrictor, so it stimulates aldosterone release from the adrenal cortex. Now, aldosterone causes retention of water, which increases blood volume. So the main purpose of the RAA system, renin, angiotensin, aldosterone, is to increase blood volume. The kidneys also produce prostaglandin E2 and prostacyclin, which help maintain renal blood flow because of vasodilation. So if the kidneys aren't getting enough blood flow, they say, hey, we need to, there's not enough pressure here, so we need to prime the pump, get more pressure coming through the kidneys so that they can do their filtration purpose. And so they produce prostaglandin E2. And that increases the arterial blood flow, therefore increasing renal blood flow. If you'll go to slide number 8, it talks about the active urination. So there's voluntary control from the higher brain centers and involuntary control from the spinal cord that influence the act of micturition or avoiding. The brain structures that influence the bladder function are the cerebral cortex, the thalamus, the hypothalamus, and the brainstem, and they inhibit the urge to void or they allow voiding. So that's why as a child grows and matures, that they can control it with their thought processes. Now, normal voiding requires the contraction of the bladder and coordinated relaxation of the urethral sphincter and the pelvic floor muscles. And it's important as nurses that we understand the process of normal voiding to be able to assess and determine which form of incontinence or which bladder problem may be occurring with the patient. Bladder capacity varies with the individual, but ranges, like we said, from 600 to 1,000 milliliters. And I told you that normally patients feel like they have to void when they have about 200 to 300 milliliters in their bladder, but a bladder can hold a lot more than that. An adult normally voids every 2 to 4 hours, and as the volume increases, the bladder walls stretch, and that stretch reflex sends impulses to the micturition center in the sacral spinal cord. Now, incontinence is classified as functional overflow, stress, urge, and total. Each type has a specific nursing intervention. We're going to talk specifically about stress incontinence. I'll try not to yawn too many times through this. Now, if a patient has damage to the spinal cord above the sacral region, that causes reflex incontinence. And that's a loss of voluntary control of urination. But the micturition reflex pathway often remains intact, allowing urination to occur without sensation or of the need to void. If a chronic obstruction caused by neurological damage, such as prostate enlargement, hinders bladder emptying, over time the micturition reflex changes, and that causes the bladder overactivity and possibly causes the bladder to not empty completely. Overflow incontinence occurs when the bladder is overly full and bladder pressure exceeds sphincter pressure, resulting in involuntary leakage of the urine. Causes often include a head injury or spinal injury, multiple sclerosis, diabetes, trauma to the urinary system. But here's one that you'll run into quite a bit is post-anesthesia sedative hypnotics, tricyclics or analgesics. So you'll run into that more frequently for hospitalized patients. Is that urinary retention. Hyperreflexia is a life-threatening problem that affects heart rate and blood pressure, and it's caused by an overly full bladder. It's usually neurogenic in nature, however. It can be caused functionally by a blockage. Okay, if you'll go to slide number 9, it talks about factors influencing urination. Disease, medications, and procedures that affect urination we're going to talk about those on later slides. So there are socioeconomic factors that will determine the degree of privacy needed for urination. Their psychological factors include anxiety and emotional stress and privacy issues. The kidneys primarily maintain the balance between retention and excretion of fluids. Symptoms common to urinary disturbances include frequency, urine urgency, dysuria, polyuria, incontinence, and difficulty in starting the urinary system. Nocturia, remember, is awakening to void one or more times in the night. Polyuria is excessive urine output. Oliguria is a decreased urinary output in spite of adequate fluid intake. And we generally say that starts oliguria at 30 milliliters an hour or less. Anuria occurs when the kidney produces no urine at all. So anuria is 0 milliliters, and oliguria starts at 30 milliliters, or is between 0 and 30 milliliters per hour. Diuresis is increased urine formation. Fever causes an increase in body metabolism and accumulation of body waste. And so although urine volume is reduced, it's highly concentrated when urine is highly concentrated when a patient has a fever. Slide 10 talks about the case study one more time. So if you'll pause here and read the case study. Okay, so Sandy is the nurse and she's working with Mrs. Valero. So what do you think is happening with Mrs. Valero? Okay, if you said that you thought that she was experiencing urinary retention, why do you think the patient's having some dribbling? Well, her bladder is full and she does have urinary retention and she's unable to empty her bladder. So she does have a case. We are going to put in a straight catheter, which is intermittent catheterization, catheterize the patient, then pull the catheter out. And she does have pale, clear, yellow urine, which means that it has not been sitting in there long for it to concentrate. Okay, the next slide, slide 11, is disease conditions affecting urination. Now, there are disease processes that affect urinary elimination that also affect renal function. So changes in the urine volume or quality and the active urine elimination, or both. Conditions that affect urine volume and quality are generally categorized as pre-renal or renal or post-renal in origin. So decreased blood flow to and through the kidney would be pre-renal. Disease conditions of the kidney would be renal tissue, and then obstruction in the lower urinary tract. So anything from the ureters on down would be considered post-renal. That alters renal function. And then conditions of the lower urinary tract, including narrowing of the urethra, altered innervation of the bladder, or weakened pelvic and or perineal muscles, do affect the urinary elimination. So, for example, diabetes mellitus and neuromuscular diseases such as multiple sclerosis cause changes in nerve functions that can lead to possible loss of bladder tone, reduced sensation of bladder fullness, or inability to inhibit bladder contractions. Older men often suffer from benign prostatic hypertrophy, or BPH, which we talked about in class, which makes them prone to urinary retention and incontinence. Some patients with cognitive impairment, such as Alzheimer's disease or a type of dementia, lose the ability to sense a full bladder or are unable to recall the procedure for voiding and need to be reminded or retaught or coached. Diseases that slow or hinder physical activity interfere with the ability to void. Then there are also degenerative joint diseases such as Parkinsonism. Those are examples that make it difficult to reach and use toilet facilities. And so that might be what we were talking about for functional incontinence. Diseases that cause irreversible damage to kidney tissue result in end-stage renal disease. And eventually the patient has symptoms resulting from uremic syndrome, an increase in nitrogenous waste in the blood, marked fluid and electrolyte abnormalities, nausea, vomiting, headache, coma, and convulsions can characterize uremic syndrome. So, and I'm telling you about each one of these so that you can be familiar with these words. The ones that we really want you to know about, we'll stress as exemplars, okay? Here in Healthcare 1 and then again in Healthcare 3. As the uremic symptoms worse, aggressive treatment is indicated, such as dialysis or organ transplantation are two methods of renal replacement therapies. Dialysis can either be peritoneal dialysis, where we use the abdomen or the peritoneum to dialyze the patient, or hemodialysis, which is where the dialysate is infused, or the blood is removed, the dialysate cleans the blood, and then the blood is put back in the patient. Patients can use both dialysis modalities for short or long term, but these treatments require specialized equipment. They're time intensive. And the last one is a new organ or organ transplant, is where the kidney is surgically implanted into the abdomen. So if you ever have a patient with kidney transplant, you'll see that they have an abdominal incision. So we don't take out either one of the diseased kidneys. We just put a third kidney in. When I worked out west, the unit was called West 6 in the hospital I was working on, and half of that floor was devoted to kidney transplant patients. I never took care of a kidney transplant patient who was not also a diabetic. We give transplant patients special medications, like immunosuppressives are administered often for life to prevent the body from rejecting the transplanted organ. Unlike other treatments, successful organ transplantation offers patients the potential for a restoration of normal kidney function so that they would not have to have any more dialysis. Okay, Slide number 12. Indications for dialysis include the following: renal failure that can no longer be controlled by conservative management, which would include dietary modifications and administration of medications to correct their electrolyte imbalances. Worsening of uremic syndrome associated with end-stage renal disease, which would include nausea, vomiting, neurologic changes, and pericarditis. And then another indication is severe electrolyte and/or fluid abnormalities that cannot be controlled by simpler measures. For example, that might be hyperkalemia and pulmonary edema. And if you look in your textbook on box 45-1, that's from page 1045. Okay, so back to the case study. So Sandy prepares to assess Mrs. Valero again. She remembers that urinary problems are common in patients who have diabetes and in older patients. And age alone does not cause incontinence. She recalls that patients with urinary retention sometimes leak or dribble urine and are then misdiagnosed as incontinent. She knows that patients generally void at least every 6 to 8 hours, and that Mrs. Valero's recent catheterization, her decreased mobility, and her history of diabetes make her very prone to urinary retention. And then incontinence of small amounts of urine and urinary tract infection. So this is an interesting case study where there's a possibility of retention and incontinence all at the same time. So what should Sandy do at the next time that she assesses the patient? If you said that she would assess for bladder fullness, assess above the symphysis pubis for bladder, I want to say bouncy bladder, but if the bladder feels full, those would be some things to assess for, and also questioning, getting some subjective assessment from the patient. Okay, slide number 14, medical interventions affecting urination, preoperative orders of nothing by mouth or an underlying disease condition affects fluid balance before surgery. This reduces urine output. In addition, the stress response releases an increased amount of ADH, antidiuretic hormone, which increases water resorption. So stress also elevates the level of aldosterone, causing retention of sodium and water. Both of these substances reduce urine output in an effort to maintain circulatory fluid volume. Anesthetics and narcotic analgesics slow the glomerular filtration rate, reducing urinary output. These pharmacological agents also impair sensory and motor impulses traveling along the bladder, spinal cord, and brain. Patients are often unable to sense bladder fullness and initiate or inhibit micturition. Spinal anesthetic in particular, we've talked about this for patients who've had renal anesthesia, such as an epidural, that creates the risk of urinary retention because of an inability to sense the need to void and possible inability of the bladder muscles and the urethral sphincters to respond. Surgery of the lower abdominal and pelvic structures sometimes impairs urination because of local trauma to the surrounding tissue. After returning from surgery involving the ureter's bladder and urethra, patients routinely have urinary catheters and continuous bladder irrigation. And the reason for the continuous bladder irrigation is so that there are no clots that form and block the catheters. Many medications directly or indirectly contribute to urinary dysfunction, so antipsychotics, antidepressants, alpha-adrenergic agonists, and calcium channel blockers can cause urinary retention and overflow incontinence. Alpha antagonists, diuretics, sedative hypnotics, opioid analgesics, ACE inhibitors, and antihistamines can cause urinary incontinence. Anti-Parkinson medications may cause urinary urgencies and subsequent incontinence. Always consider that these medications as the cause of new onset urinary incontinence, especially in older adults. So very important to pay attention to which medicines. Some medications change the color of the urine. For example, pyridium colors the urine a bright orange to rust. Amitriptyline causes a green or blue discoloration, and levodopa discolors the urine to black or brown. Cancer chemotherapy drugs also color the urine and are often toxic to the bladder and or kidneys. Patients with impaired kidney function require dosage adjustments in medications excreted by the kidneys. Examination of the urinary system influences micturition. Some procedures, such as an intravenous pyelogram, require patients to limit fluids before the test. A restriction in fluid intake commonly lowers the urine output. Diagnostic exams, such as a cystoscopy involving direct visualization of the urinary structures, cause localized edema of the urethral passageways and spasm of the bladder sphincter. And so after these procedures, a patient may have difficulty voiding or may have red or pink urine caused by trauma to the urethral or bladder mucosa from bleeding. In slide 15, it talks about alterations in urinary elimination. As urinary retention progresses, retention with overflow develops. Bladder distension is apparent. With retention, the patient may void small amounts of urine 2 to 3 times an hour with really no relief because they aren't able to empty their bladder effectively. Urinary tract infections are usually caused by E. coli, bacteriuria, or bacteria in the urine leads to the spread of organisms into the kidneys and possibly to bacteremia, which is bacteria in the bloodstream. Those microorganisms commonly enter the urinary tract through the ascending urethral route. Bacteria inhibit the distal urethra, the external genitalia, the vagina for women. Women are much more susceptible to urinary tract infection because of the short urethra and close proximity to the anus for contamination from the E. coli. Now, burning during urination is also known as dysuria, as the urine passes through inflamed tissues. An irritated bladder is known as cystitis. Irritation of the bladder and urethral mucosa causes hematuria. If infection spreads to the kidneys, pyelonephritis occurs with the symptoms of flank pain, tenderness, fever, and chills. We won't use pyelonephritis as one of our infection exemplars, but we do use UTI, and because it's such a common infection that patients get. Urinary incontinence can be temporary or permanent and continuous or intermittent. Urinary incontinence can affect patients of any age, but it is very prevalent in the elderly. Causes can include problems with movement, removing clothing, mental incapacity. Some patients may have urinary stoma to divert the flow of urine from the kidneys to an external stoma. This may be necessary because of trauma, cancer, radiation, fistula, or chronic cystitis. The types of diversions include an ileal loop or conduit, continent pouch, or a nephrostomy. We'll talk about some of those on slide 21. All right, for older adults, we want to make sure we provide frequent opportunities for them to void. Older adults can have a smaller bladder capacity than younger adults. Some people say if you don't use it, you lose it. So if you void frequently, then the ability to let your bladder stretch and hold more urine is lost. We want to encourage the older adults to empty their bladder completely before and after meals and at bedtime. Discourage the drinking of coffee, tea, brown, cola, and alcohol because they have a diuretic effect and increase urinary frequency. The caffeine is an irritant. Make fluids such as cranberry juice available as part of the patient's fluid intake. Cranberry juice, vitamin C, all help acidify the urine to decrease bacterial infections of the bladder. Most important thing, though, is not what kind of fluid, but that there is fluid. So drinking plenty of water would be just as good. Restricting fluid intake does not decrease urinary incontinence severity or frequency. A lot of older adults put that restriction on themselves by saying, oh, I don't drink anything after this time of night. But it does not decrease the urinary incontinence, the severity of it. We want to make sure that we avoid, and I want to stress this, avoid the use of an indwelling catheter. If one is necessary, use it no longer than it is necessary. We don't use catheters for patients because it's convenient for the nurse. We don't use them because we're tired of diapering the patient. We use them because because there is a true medical need for the patient to have a urinary catheter. and then only use it as long as it's necessary. I've worked with the students, the older students, for quite some time, and it's really interesting. I have said this in Healthcare 1, and by the time I see them the next year, they're busy trying to put a catheter in patients for incontinence reasons that are not, it's not warranted. And I find that to be very interesting because I know I've said in this class in Healthcare 1, we don't put a catheter in a patient just because we're tired of diapering the patient or because it's inconvenient. The risk of infection is just too high. It increases dramatically for catheterized patients. And that type of urinary tract infection is called CAUTI, C-A-U-T-I, catheter-associated urinary tract infection. Now, I want you to note that incontinence is not a normal part of aging. And please make efforts to assess incontinence and provide interventions to promote the return to continence. Older patients, just because they are elderly, should not experience incontinence as it is not a normal process of aging. Okay, quick quiz. Go ahead and pause and take the quick quiz question. All right, if you selected D, that is the correct answer. Small amounts of urine voided 2 to 3 times per hour. Why is that a sign or symptom of a urinary retention? Overfull bladder, that is correct. All right, here's the case study on slide number 18. Sandy knows that she will need to assess whether Mrs. Valero feels the urge to urinate. She determines that no one has taken Mrs. Valero to the bathroom recently. Sandy also needs to find out more about her patient's urination patterns at home because Mrs. Valero has verbalized anxiety about her present voiding patterns. Previous clinical experience has taught Sandy that palpation of the abdomen over a distended bladder causes some discomfort, so nurses must do that very carefully. And that the patient often experiences an urge to urinate. Mrs. Valero grimaces when her abdomen is palpated and says she has a little dolor, which is the Spanish word for pain. Now, what additional assessment activities should be performed routinely? What would you incorporate into Mrs. Valero's plan? Mrs. Valero has heart failure and a bed rest have left Mrs. Valero in a weakened state. So Sandy's flexible and she's creative in designing a plan of care to meet the patient's elimination needs. But what additional assessment activities should be performed routinely? And what would you incorporate into Mrs. Valero's plan? And I would encourage you to stop for a moment and as part of ADPI, I'd like you to write a plan. And what further assessments should be performed? That would be in your interventions under ATT, A for further assessments, and treatment is the second one, and teaching is the third one. So what needs to be on the nursing care plan? This is a quick picture on slide number 19 about types of urinary diversions, and I'm sure that you have seen those. That is on page 1048. Conditions such as bladder cancer, radiation, injury to the bladder, chronic urinary tract infection may necessitate a urinary diversion to drain urine from a diseased or dysfunctional bladder. I would say bladder cancer is the most common one. 2 types of continent urinary diversions may be performed. A continent urinary reservoir is created from a distal portion of the ileum, this is A, and a proximal portion of the colon. The ureters are embedded in the reservoir, and this reservoir is situated under the abdominal wall and has a narrow ileal segment brought out through the abdominal wall to form a small stoma. So when you look at a patient's abdomen, if you did not know if they had a bowel diversion or urinary diversion, if it's a very small stoma, then it is, generally speaking, it's a urinary diversion. The ileocecal valve creates a one-way valve in the pouch through which a catheter is inserted to empty the urine from the pouch. Patients must be willing and able to catheterize the pouch 4 to 6 times a day for the rest of their lives. The second type is an orthotopic neobladder that also uses an ileal pouch to replace the bladder. Anatomically, the pouch is in the same position in which the bladder was before removal, allowing patients to void normally. Incontinent urinary diversions are less commonly performed. Surgery involves connecting the ureters to a section of the intestinal ileum with formation of a stoma on the abdominal wall. The urine drains continuously because the patient has no sensation or control over urinary output, requiring the application of a collection pouch at all times. Some patients need urinary drainage directly from one or both kidneys. In this case, a tube is placed directly into the renal pelvis, and this procedure is called a nephrostomy. Any urinary diversion poses threats to a patient's body image. The patient must learn how to manage the diversion, and those who do not have a continent urinary diversion must wear an artificial device at all times, which means a bag. However, most patients are able to wear normal clothing, engage in physical activity, travel, and have sexual relations. Care must be taken not to pull on the tubing, especially with a nephrostomy, because it can be pulled out, causing tissue and organ damage and infection. Most nephrostomies are sutured into the kidney. The nephrostomies that I have seen have been placed on the back, and they've been temporary ones, but are placed in the back, and the tube comes right out of the patient's back and then into a collection pouch. Looks like a Foley bag. Okay, so there are special nurses who do take care of this. They're called WOC nurses, WOC, wound, ostomy, and continence nurses. And they have specialized education in this area. So whenever you hear about the WOC nurse, that's someone who has specialization in wound, ostomy, and continence. And it's a valuable resource for assisting a patient and a family with matters pertaining to all aspects of ostomy care. And they often meet with the patient and family before surgery, talk about what the ostomy will look like afterwards, help them to be prepared. There's also a United Ostomy Associations of America website you can go look at. That's uoaa.org. And that organization provides information about support groups to enhance coping and adaptation to lifestyle and body image changes. You're going to learn all about ostomy care in Clinical 3. Okay. Now, nursing knowledge base. Recall that for many, the act of urinary elimination is a private process. Remember that the urinary tract is sterile. The use of infection control principles will help to prevent the spread of a urinary tract infection. Increased fluid intake results in increased diluted urine formation. That means it would have a low specific gravity, which reduces the risk of urinary tract infection. Growth and development factors will determine the patient's ability to control the act of urination across the lifespan. So infants, children, and the elderly experience more problems with urination. The young need to learn to recognize the need to urinate. The elderly need to deal with decreased functioning that accompanies age. Weak abdominal and pelvic floor muscles that impair the ability of the urinary sphincter to maintain tone. Immobility, muscle damage during vaginal delivery, muscle atrophy, or trauma contributed to problems with urination. Psychosocial issues such as body image, self-esteem, roles, and identity may influence urination. Gender differences, culture influences the act of urination. Urinary problems may not be treated in the Western tradition. Culture may also dictate how and when a patient urinates. In some cultures, patients urinate in a squatting position, and it will be important to render culturally competent care. All right, so let's get on talking about the nursing process and assessment. So your nursing history includes a review of elimination patterns. What are the normals? So you can identify abnormals, symptoms of alterations, and other factors. Box 45-5 on page 1051. 45-5, yes. Presents nursing assessment questions to ask. I would encourage you to look at that. And then table 45-1 on page 1051 also presents some common types of urinary alterations. Factors that affect urinary alterations include environmental factors, medication history. Remember we said there are quite a few medications that can cause urinary retention or incontinence. Psychological factors, muscle tone, fluid balance, current surgical or diagnostic procedures, and the presence of a disease. So if you look at figure 45-5 in the textbook on page 1050, it talks about a critical thinking model for urinary elimination assessment. And so that looks at knowledge, attitudes, experience, standards. So I would encourage you to look at that critical thinking model. And then box 45-3 on page 1050 talks about cultural aspects of care. Some of those that I would encourage you to pay attention to are implications for practice. One of the things that I frequently tell students who do not have English as a first language, but where English is a second language, that you need to use simple and clear sentences in communicating with patients. Remember what proper words are for urination. We have a lot of shortcut words that maybe we use with children, but when we're dealing with adults, we need to use proper words such as voiding, urination, micturition. Sometimes patients won't know what that means, so another appropriate way to say that would be letting the urine out or letting water out. I know that there are lots of crude ways to say that, and I would encourage you as healthcare professionals to not to engage in that. All right, so if you'll read that box 45-3, that will give you some very clear guidelines about how to talk about urination with patients who may not be of the same cultural background as you. All right, slide 22. So here's the case study continued. The patient is able to palpate the bladder, indicating bladder distension. During palpation, the patient states she has the sensation of bladder fullness. Let's say that the nurse is palpating the bladder, and they also notice that the patient is dribbling frequently and while being unable to urinate. So what are the specific assessment activities that produce these findings? Well, it was actually palpating the bladder to detect the bladder distension every 2 hours on the even hours. So it would be important in your care plan to say palpation of the bladder every 2 hours to assess for bladder fullness. The assessment of the patient's voiding pattern would also need to be assessed, and including the volume at each voiding, the frequency, the time of day, and any history changes. Okay. Okay, I'm hoping this is still working. I'm still talking. Okay, I am on slide number 23, urine collection in children. It often helps to offer the child fluids 30 minutes before requesting a specimen. You need to use terms for urination that the child is able to understand. So sometimes it's good to ask the mom, what do you normally use as term, or the parent, whoever comes in with them, what terms do you use for urination so that the child will understand. And a young child is often reluctant to void in unfamiliar receptacles. A potty chair or specimen hat placed under the toilet seat is usually effective, but it depends on the age of the child and how comfortable they are. I know over at Children's Hospital we have little potty chairs that we bring in for the children who are potty training, who might be hospitalized, instead of having to put them back in a diaper. You'll need to use special collection devices for infants and toddlers who are not toilet trained. You can attach a clear plastic single-use bag with a self-adhering material over the child's urethral meatus. They look a little bit different for the baby girls versus the baby boys. You do not want to obtain the specimens by squeezing urine from the diaper because the results will be inaccurate. I know that seems like a really easy way to do it, but there are fluid-absorbing molecules in the diaper, and if you wring out the diaper, then that will alter the results of the urinalysis. All right, quick quiz on slide 24. A young girl is having problems urinating postoperatively. You remember that children have trouble voiding in bathrooms other than their own, in a urinal, while lying in bed, in the presence of a person other than their parents. And some of those you might feel compelled to choose in the bathroom other than their own, or while lying in bed. Those might be, but the strongest answer there is D, in the presence of a person other than their parents. All right, slide 25. We are at the halfway point. Physical assessment. Your knowledge, experience, standards, and attitudes will play critical roles in the assessment process. Applying the nursing process and use of critical thinking in the care of patients. The nursing process provides a clinical decision-making approach by which you can develop and implement an individualized plan of care. During the assessment process, thoroughly assess each patient and critically analyze findings to ensure that you make patient-centered clinical decisions required for safe nursing care. Successful critical thinking requires synthesis of knowledge, experience, information gathered from the patient's critical thinking attitudes, and intellectual and professional standards. Clinical judgments require you to collect necessary information, analyze the data, and anticipate and make decisions regarding patient care. So if you would look once again on figure 45-5 for critical thinking model for urinary elimination assessment. All right, slide 26. Part of the physical assessment, to identify urinary elimination problems and gather data for a care plan. You want to make sure you conduct the nursing history, perform a physical assessment, assess the patient's urine, and review information from the diagnostic tests and examinations, and to synthesize this information to make clinical judgments. You want to look at the skin and mucosa, assess the skin's hydration by looking at turgor and texture. An easy way to check turgor is right here over the clavicle. Kidneys, we want to with advanced skills, you can, well, the main one you can do is CPA tenderness. Then the bladder normally sits below the symphysis pubis, so you want to palpate that gently. Percussion should produce a dull tone. In inspecting the urethral meatus, I know we talked about the fact that you had not done that in your physical assessment class, holistic health assessment, but that would be something that you were going to do now as you took care of patients. And I encourage you to have your clinical instructor go with you and assess that. The female patient will need to lie on the dorsal recumbent position to expose the genitalia, using gloved hands to retract the labia to observe the urethral meatus. Look for drainage or lesions and ask the patient if this is uncomfortable. Drainage indicates infection, especially if it's has white or yellow discharge. The male's meatus is normally a small opening at the tip of the penis. Inspect the meatus for discharge, lesions, inflammation. For an uncircumcised patient, you will need to retract the foreskin. In the skills lab, you'll learn how to measure and document intake and output. You probably learn to do that in CNA, but remember that hourly output of less than 30 milliliters for longer than 2 hours is cause for concern and further assessment. The color of the urine should be pale, straw to amber. Urine usually is more concentrated in the morning. And like we said, medications can change the color, as can some vegetables such as beets, rhubarb, blackberries, blueberries. Dark amber urine is the result of bilirubin from liver disease. Stagnant urine has a strong ammonia odor. A sweet or fruity odor is often seen with diabetes or starvation, when patients are putting out a lot of ketones. Excuse me. I don't have a pause button. I just realized I was going to pause, but I don't have a pause button. Okay. You are going to learn how to collect specimens, urinary catheterization in the skills lab this semester if you haven't started already. And like we talked about in class, that you can collect specimens with a clean catch, or what we call voided midstream, or they can be sterile, a sterile specimen. which is catheterized. We did talk about urine tests and diagnostic examinations. We did talk about a urinalysis, and I told you that you would need to memorize the normals. There are normals in Potter and Perry on page 1054, on table 45-3. Those are probably very similar to what ATI has. Remember, we talked about that there shouldn't be any glucose, ketones, blood, or protein in the urine. That the pH should be it does indicate the acid-base balance. And then we talked about specific gravity for the dilution of the urine, or the degree of concentration. When collected properly, a clean voided urine specimen does not contain bacteria from the urethral meatus. A urine culture requires a sterile or clean voided urine sample. It usually takes 24 to 48 hours to reveal the findings of bacterial growth. A test for sensitivity will determine which antibiotic will be most effective. Talked about that, culture and sensitivity. Now, for non-invasive examinations, we talked about the KUB, which is an abdominal X-ray plain film, which stands for kidney, ureter, bladder, or it's called a flat plate. Another non-invasive procedure is the CT, or the computed tomography scan, or IVP is intravenous pyelogram, which is where they shoot dye into the patient's vein, and then they watch that dye as it goes into the kidneys to see how it disperses through the kidneys. Then there are the invasive examinations, which is cystoscopy and arteriography. So a patient, for example, if we need to go in and see how well the renal artery is working, they can put a catheter in the femoral artery. And as it goes up through the abdomen, you can take a detour and go shoot dye through the renal artery and see how the blood flow in the kidneys. Remember that each examination has a specific indication and use. Some have a bowel preparation, patient education. Some examinations will require a signed consent form. For example, when they're doing the pyelogram or the arteriography, we want the bowels to be completely cleaned out so that we can see the kidneys and the blood flow clearly. So we don't want any stool in the abdomen. You also want to make sure that the patient isn't sensitive to dye, and that would be where you would ask them if they have any iodine sensitivity. Page 1055 in table 45-4 talks about those diagnostic examinations if you want to go and review those. All right, slide 29 looks at a urine drainage bag. When a lot of times we'll call them a Foley catheter, but it's actually, Foley is the brand name. And so when you measure urine from a drainage bag, you want a separate plastic graduated measuring receptacle. And we call those graduated cylinders. Each patient needs to have a graduated cylinder for his or her exclusive care to prevent potential cross-contamination. You want to make sure that you label each container with the patient's name. Needs to be rinsed after emptying, and the tubing that drains the bag securely clamped and cleaned with an alcohol before it is put back in the holder. Report any extreme increase or a decrease in urine volume. Daily output generally ranges between 1,200 to 1,500 milliliters of urine a day. Hourly output, like we said, should be more than 30. And if you have a patient who is consistently putting out high volumes of urine, polyuria, such as over 2,000 milliliters a day, that also needs to be reported. Slide number 30 is urine specimen collection, where you can see where the port, so the red part is where the yellow catheter hooks on, and then the white that's pointing up there, that is going towards the urine collection bag. And so this would be a method of collection for drawing urine out of a Foley catheter. This would be aspiration from a collection port in the drainage tubing of an indwelling catheter. And you can see that that's a needleless technique. I would encourage you to look at table 45-2 on page 1053 for where it talks about urine specimen collection. All right. Slide number 31 is checking results of a chemical reagent strip. Depends on the facility where you're working if you can do urine dipstick. This is a nurse checking the results of a chemical reagent strip dipped in urine. I know that facilities, if you do have to dip the urine, you also have to have a color blindness test to make sure that you can actually see all the colors. If you cannot see the colors, because most commonly, the most common color blindness test or deficit is for men who cannot see the color of blue. So for a quick screening, you want to perform certain portions of the urinalysis with a special reagent strip. You dip the strip into the urine and you wipe it off with the backside with Kleenex, and you observe for a color change in the time interval designated on the package. Number 30, slide 32 is as we've talked about, all kinds of assessment. Now we're on to nursing diagnosis and planning. Some diagnoses are common to patients with urinary elimination alterations. A general goal is often normal urinary elimination, but sometimes the individual goal differs depending on the problem. Consider the patient's home environment and normal elimination routines when planning the therapies. Collaborate with several healthcare disciplines. You might be working with a urologist or a nephrologist for these particular patients. If you look at box 45-5 on page 1056, it is stress urinary incontinence related to weakened pelvic musculature. And then figure 45-9 on page 1056 looks at a model for urinary elimination planning. Really want to focus on figure 45-10, and that is a nursing care plan for urinary incontinence. I would encourage you to look at that, the assessment, the planning. Like I told you, I'm not so worried that planning, that goals and outcomes, to me, those are all kind of the same things. But NOC stands for nursing outcomes, and NIC are nursing intervention classifications. Those are standardized. I would encourage you when you go to the hospital to look in the nursing care plans of your patients in the electronic health record, and you will see the NOC and NIC, those standardized outcomes and standardized interventions. Those can be very helpful to you as you're looking at those. And then over on page 1058 are further interventions, and then look at the evaluation portion of that. Down below that is a concept map. So if you are opposed to care planning or you struggle with that, concept mapping might look a little bit easier to you. And I would encourage you to look those over. Each one of those has it has assessments in the center, and then the nursing diagnosis, and then interventions. Skipping over the planning portion a little bit on the concept map. Alrighty, on slide 33, the case study is continued, and I'm going to have you look that nursing case study over. Go ahead and hit pause and read that. The nursing diagnosis is that urinary retention related to weakened detrusor muscle and recent removal of indwelling urinary catheter. The goal is that Mrs. Valero will have normal micturition within 1 month. And we would like to, I would include in that goal that she'll void more than 150 milliliters each time she voids, that she will verbalize no episodes of dribbling or incontinence, that Mrs. Valero will verbalize relief of lower abdominal discomfort. So all of those could be outcomes, expected outcomes included in that goal. On slide 34, it starts talking about implementation. And this is really the meat and potatoes. What is the nurse going to do? To start off with our primary prevention, we want to look at health promotion. So we want to, different things that interventions that nurses can employ would be maintaining normal urinary elimination helps to prevent many urinary problems. Many nursing measures promote normal voiding in patients at risk for urination difficulties and in those with established urination problems. Methods of promoting the micturition reflex help patients sense the urge to urinate and control urethral sphincter relaxation. A patient's ability to void depends on feeling the urge to urinate, being able to control their urethral sphincter, and being able to relax during voiding. We want to help patients learn to relax and stimulate the reflex to void by helping them assume the normal position for voiding. A woman is better able to void in a squatting or a sitting position if she is unable to use toilet facilities. Then you want to position them as close to that as possible. Position the patient in a squatting position or on a bedpan or a bedside commode. Other measures that promote relaxation and the ability to void include sensory stimuli. The sound of running water helps many patients void through the power of suggestion. Stroking the inner aspect of the thigh stimulates sensory nerves and promotes the micturition reflex. You can also pour warm water over the patient's perineum and create the sensation to urinate. If you need to measure urine output, first measure the volume of water that you pour over the perineal area. That might help when you're working with a patient who has to lay flat on a bedpan. Integrating patients' habits into the care plan fosters normal voiding and helps prevent problems related to urination. A simple method of promoting normal micturition is maintaining optimal fluid intake. Also, encouraging patients to wait until urine stops flowing or to attempt to void again. Double voiding can improve bladder emptying. One of the most important considerations is to prevent infection of the urinary system. Hottie. Don't use a catheter unless one is indicated. So table 45-5 on page 1060 of urinary incontinence and treatment options, and box 45-6 on page 1059 that talks about teaching patients urinary elimination problems related to urinary sphincter dysfunction. All right, slide 35. These are types of male urinals. I'm sure that you've seen those. This would be for a patient either in a standing or a laying down position or sitting, any of the three. And slide 36. Back to the case study. Interventions for urinary retention care include assist with toileting every 2 to 3 hours while awake. So we want to make sure scheduled toileting is the primary behavioral intervention used for chronic retention and is used to reduce bladder capacity. We want to make sure we're keeping a record of the urinary output, and that's important to confirm voiding in small amounts. It's also important to note the amount urinated before obtaining residual urine, which means the patient would void, and then to obtain the residual urine, you either use the bladder scanner or you go in with a catheter. Relaxing in a bath eases discomfort and induces micturition. We have to make sure the patient's not at risk for urinary tract infections because bathing can cause, in some patients, an increase in urinary tract infections. And then Credet's method, so that's called Credet, involves putting pressure on the suprapubic area and is used for relief of urinary retention. So that's basically pressing from the top of the bladder down towards the symphysis pubis to help the patient void. We do use that quite frequently in OB when we're assessing the I just drew a blank, I can't believe it. The top of the uterus. I don't know, I wanted to say urethra, and I knew that wasn't the right word. Knew it started with a U. Okay. Slide 37. Patients usually require time to void. Requesting a urine specimen on demand does not contribute to relaxation and normal voiding habits, so give patients at least 30 minutes to provide a specimen. Many patients need privacy while voiding. If a patient cannot reach the bathroom and uses a bedside commode or bedpan, make sure that the patient curtain, like the curtain is closed, or that you bring the sheets up over the patient, something to help provide them with privacy, even though they can't get into a closed room for privacy. Drug therapy given alone or with other therapies often helps problems of incontinence or retention. The bladder is innervated by parasympathetic nervous system. Drugs that block the muscarine receptors suppress bladder contractions and reduce incontinence caused by bladder irritation. So, and when the bladder empties, the detrusor muscle contracts in response to parasympathetic stimulation. Incomplete bladder emptying results from impaired innervation or weakness of the detrusor muscle. The patient experiences retention and possible overflow incontinence, so cholinergic drugs increase contraction of the bladder and improve emptying. Catheterization of the bladder involves introducing the plastic tube through the urethra into the bladder. The catheter provides continuous flow of urine in patients unable to control micturition and in those with obstructions. But it's a last resort. Catheterization, now on slide 38, can cause a UTI, it can cause blockage, and it can cause trauma to the urethra. So if you would look on page 1061 in box 45-7, it talks about indications for catheterization, for intermittent and then short-term indwelling catheters, and then a long-term indwelling catheter. A catheter drainage system should be a closed system positioned to allow free drainage of urine by gravity. For patients who have to do repetitive catheterizations, they might they might use, if they're doing it at home repetitive times during the day, they might just have a red rubber catheter and then just sit on the toilet, catheterize themselves, and let the urine drain right into the toilet. Generally speaking, drainage systems are a closed system to allow free drainage of the urine by gravity. You need, in order to insert a catheter, you must use sterile aseptic technique in the nursing skills lab. If, like I say, I didn't look at the schedule, but you may have already learned how to insert both the straight and indwelling. I don't think you've come to that yet in this semester, but it's coming. After inserting an indwelling catheter, you want to maintain a closed urinary drainage system to minimize the risk of infection. So once the urinary catheter and the drainage system are connected, we don't want to ever break that open. Sites for breakage in the system include the drainage bag, the spigot, the bag juncture, the junction of the tube in the bag. Most drainage bags contain an anti-reflux valve so that it prevents the urine in the bag from re-entering the drainage tubing and contaminating the patient's bladder, but we don't always know that. So the bag should never be held up higher than the level of the bladder to prevent reflux back into the bladder. You want to make sure you follow specific guidelines so that the catheter does not cause any harm or trauma to the patient. And catheter care is that you provide perineal hygiene at least 3 times a day, or as needed for a patient with a retention catheter, which is a urinary catheter in them. You need to check the healthcare facilities policies and procedures for catheter care. They should have a daily intake, unless they're on fluid restriction, of at least 2 liters a day, so 2,000 to 2,500 milliliters. Catheter irrigations or installations can be used to maintain the patency of an indwelling urinary catheter, but you need to have an order for that. Things that can block a urinary catheter are blood, pus, sediment that collects in the tubing, and buildup of urine. An indwelling catheter remains in the bladder for an extended period, making the risk of infection greater than with intermittent catheterization. So sometimes you think, oh, if I put the catheter in once, that would be better than leaving it in would be better than going in 3 times in a day with a straight cath, and that is not the case. 3 straight caths done under proper technique is better than an indwelling catheter, a Foley catheter staying in. They say the evidence is once you have to put one in 4 times, then that's when the benefit of a straight cath is less than the benefit of a Foley cath. So three times straight cath, superior to Foley cath. If you go to the 4th time, then a Foley cath should have been put in. So if you anticipate that the patient's going to need to be straight cath repetitively, then a Foley cath should be your first choice. When removing an indwelling catheter, promote normal bladder function and prevent trauma to the urethra. Suprapubic and condom catheters are 2 alternatives to indwelling catheters. Suprapubic catheterization requires surgical placement of catheter through the abdominal wall above the symphysis pubis into the urinary bladder. Maintenance of the tubing and bag is the same as for an indwelling catheter. A condom catheter is only used for male patients, and it's where a condom is placed on the penis and it has an adhesive on the inside of the condom. So as you roll the condom up onto the patient's penis, it can stay, the stickum, the adhering, the glue causes the condom to stay on the penis all the time. If you want to see those, there are some pictures. There are figures. Types of urinary catheters here on slide 39. Intermittent and indwelling retention catheterizations are the 2 forms of catheter insertion. For the intermittent technique, you introduce the straight single-use catheter long enough to drain the bladder, 5-10 minutes. When the bladder is empty, you immediately withdraw the catheter. You can repeat intermittent catheterization as necessary, but each catheter insertion increases the risk of trauma and infection. It is common for people with spinal cord injury or other neurologic problems such as multiple sclerosis to perform self-intermittent catheterization up to every 4 hours daily for months or years. That's what I was just talking about with the red rubber catheter sitting on the toilet. If done correctly with the use of clean technique, they frequently do not experience more UTIs. In fact, UTI rate is lower than for patients with long-term indwelling catheters. An indwelling or Foley catheter, which is B, remains in place for a longer period until a patient is able to void voluntarily or until continuous accurate urine measurements are no longer needed. A second type of intermittent catheter has a curved tip, and that's called a coude catheter. It's used on male patients who may have enlarged prostates that partially obstruct the urethra, and it is less traumatic during insertion because it is stiffer and easier to control than the straight-tipped catheter. So those are some different information about types of urinary catheters. They are available in many diameters to fit the size of a patient's urethral canal. Generally on an adult med-surg unit, we only have one size. It's 14 French. But I do want to tell you that on the pediatric units, they have many different sizes. And the number, the higher the number, the smaller the diameter of the catheter. Same for IV catheters as well. The higher the number, then the smaller the diameter. All right, slide number 40. This is figure 45-13 from the text, page 1063. These are potential sites for introduction of infectious organisms into a urinary drainage system. Follow good hand hygiene techniques. Do not allow the spigot on the drainage system to touch a contaminated surface. Only use sterile technique to collect specimens from a closed drainage system. If the drainage tube becomes disconnected, do not touch the ends of the catheter or the tubing. Wipe the end of the tubing and the catheter with an antimicrobial solution before reconnecting it. Ensure that each patient has a separate receptacle for measuring urine to prevent cross-contamination. Prevent pooling of urine in the tubing and reflux of urine into the bladder. Avoid raising the drainage bag above the level of the bladder, like we talked about. And if it becomes necessary to raise the bag during transfer, then clamp the tubing or empty its contents into the drainage bag first. Provide for drainage of urine from the tubing to the bag by positioning the tubing. Before exercise or ambulation, drain all the urine from the tubing into the drainage bag. Avoid prolonged kinking or clamping of the tubing. Empty the drainage bag at least every 8 hours. If you note large outputs, then obviously empty them more frequently. There are some types of catheters that have a hard plastic collection device on the front. Those are called urometers, and then all you have to do is lift up that hard plastic part and it dumps into the soft plastic bag. Encourage fluid intake if it's not contraindicated. Remove the catheter as soon as it's clinically necessary. Tape or secure the catheter appropriately to the patient, generally secured to the leg. Perform routine perineal hygiene per agency policy and after defecation or bowel incontinence. That is very important to make sure that any E. coli from the stool does not adhere to the catheter and then climb up the catheter. And then in slide 41 is a picture of a condom cath. Depends on the need of the client. Sometimes they're on all the time. Other patients wear them only at night or continuously, depending on their needs. They frequently have to be replaced because the adhesive sweats off or the urine just doesn't stay adhered. If the shaft of the penis is the skin has to be intact and free from swelling, redness, lesions before you can apply the catheter. I think that's about all you need to. Slide 42 is applying the condom catheter. And then here's a picture on slide 43 of a leg bag. In case you have not seen a leg bag, you might see a leg bag with a condom cath or a straight cath with the balloon holding the cath in. So those are different. That's a different drainage collection system. All right, external urinary devices is slide 34 or 44, excuse me. Those are for if a patient has for a man with a retracted penis, maintaining a conventional condom catheter often proves difficult, so you might need special devices are available to help alleviate this problem. There are no collection devices for women, such as a condom cath for men. Thus, frequently the only devices used are pads or protective clothing. To maintain dignity, do not refer to pads and protective clothing as adult diapers. We frequently call those briefs, and change them frequently to control for odor. Use these products only temporarily or to minimize or prevent episodes of incontinence while the treatment is ongoing. Our goal is always to return the patient to normal elimination patterns if possible. We want to monitor the patients frequently to provide good skin care and prevent irritation caused from the urine. Some manufacturers have developed a female urinal, however, its ease of use may be an issue. I've not ever had a patient use a female urinal very successfully. All right, slide 45, implementation of restorative care. Some of our goal, like I said, our main goal is to help the patient return to normal urination. So patients who have stress or urge incontinence and difficulty starting and stopping urination may benefit from pelvic floor exercises. These are frequently called Kegels exercises. They improve the strength of the pelvic floor muscles and consist of repetitive contractions of muscle groups. The goal of bladder training is to reduce voiding frequency and perhaps increase bladder capacity. This method provides a specific program for patients who have a decreased urge to void or who have stress incontinence because it keeps the bladder from getting full. Thus, less dribbling occurs. A patient with functional incontinence benefits from habit training, which helps patients improve voluntary control over urination. A patient establishes a flexible toileting schedule based on his or her pattern. Some patients with chronic disorders, such as a spinal cord injury, learn to perform self-catheterization. The normal acidity of urine is irritating to the skin, so urine that is allowed to remain in contact with the skin becomes alkaline, causing incrustations or precipitates to collect, or causes precipitates to collect on it, fostering breakdown. Patients with urinary alterations become uncomfortable as a result of the symptoms of urinary problems. Frequent or unpredictable voiding, dysuria, and painful distension are sources of discomfort which need to be dealt with, and perhaps pain assessment of their pain, a cold spa to go along with that. The incontinent patient gains comfort from having clean, dry clothing. I don't think any of us would argue with that. All right, finally on slide 46, evaluation of the client. In the plan of care, ADPI, the E stands for evaluation. The patient is your best source of evaluation of outcomes and responses to the nursing care. The patient's response to questions about urination. Do they seem hesitant or embarrassed? Psychosocial factors such as culture or sexuality sometimes influence the patient's response because urination is often considered a private matter. Some people find it difficult to talk about their voiding habits. Remember that urinary elimination problems are not just physiological in nature. Be sensitive to any changes in self-concept and sexuality. They can be psychosocial in nature as well. Self-concept, which includes body image, self-esteem, roles, and identity, develops over a lifespan because the penis is an organ for both urination and sexual reproduction. Urinary dysfunction often greatly affects a man's self-concept. So what are some examples of questions to ask during the evaluation step? Pause for a moment and write down what are some questions that you would ask the patient to evaluate the plan of care. All right, so some examples of questions to ask during the evaluation step. Possible answers include, tell me, how frequently are you voiding now? Do you continue to have a feeling of urgency every time you void? Have the symptoms of urgency decreased since you changed your caffeine intake? Do you still have burning when you pass urine? Do you still feel uncomfortable over your lower abdomen? Slide 47 is the end part of the case study. Sandy talks with Mrs. Valero the next evening. The patient's care plan incorporates scheduled voiding, oral fluids, and use of the Creday's method of manual compression during voiding. She palpates Mrs. Valero's bladder softly, and then assists her to the toilet. After making sure she is comfortable and leaving the call light in place, Sandy instructs her to use Creday's method of manual compression. She returns to measure Mrs. Valero's urinary output and evaluates for bladder residual using an ultrasound bladder scan. So what would Sandy put in the documentation note about this stage? I wish this had a pause on it, but it does not. All right, Mrs. Valero. We want to ask Mrs. Valero about her urge to void, sensation of bladder fullness and dribbling episodes. Have Mrs. Valero keep a log of her pattern of elimination, including urine output volumes, when she had each void during that 1 month period. And then ask if she continues to have lower abdominal pain. So what responses would be consistent with achievement of each outcome? And if you'll recall, we wanted her to, let's see, if you go back to, I'll have to look here, slide. Just a minute. Which slide was that? Just a minute. I know I have it right here. Expected outcomes on slide 33. Mrs. Valero will verbalize no episodes of dribbling or incontinence. And so to connect with that, The outcome achieved is that dribbling episodes and sense of urgency are relieved. Okay. Number 2, Mrs. Valero will verbalize relief of lower abdominal discomfort, and the evaluation for that is urinary output is greater than 150 milliliters with each void. Nope, I missed one. Lower abdominal discomfort is absent. And then the third one is Mrs. Valero will void greater than 350 milliliters each time, and it's achieved. I think that's too much, 350. It's achieved when she has, when she's voided greater than 150 milliliters with each void. All right. Now, teaching strategies. Here we go. On slide 49. We want to make sure that teaching evaluation strategies was covered, so we want to make sure we go over them. Here's the case study. On slide 49, Mrs. Valero is concerned about regaining her urinary function. Sandy develops the following outcome for her. At the end of the teaching session, Mrs. Valero will be able to describe approaches to promote normal urinary elimination habits. So what teaching strategies would you put into the plan? What evaluation strategies would you use? All right. I would encourage you to pause for a moment and see which teaching strategies you would put in the plan and how you would evaluate them. Okay, so teaching strategies I would encourage you would be to, first of all, establish rapport with the patient, and then find out what Mrs. Valero already knows about good practices for urinary health, and use the correct terms for the anatomy that you will discuss, but explain them to Mrs. Valero so she knows what they are, so that you're not using layman's terms, but that you're using correct terms. Provide appropriate visual diagrams and written materials for Mrs. Valero if necessary. Instruct her in observations to make regarding the urinary output. So teach her what the urine should look like, how much it should be. Instruct her in adequate fluid intake and incorporate her fluid preferences into that. And encourage her to decrease caffeinated fluid intake. Discuss how to do intake and output measurement at home. You'd want to make sure you sent her home with a hat or two that she could rinse out and clean. Reinforce correct perineal hygiene measures to reduce the risk of urinary tract infection. And reinforce the correct perineal hygiene measures to reduce the risk for urinary tract infection that she's bathing and cleaning and wiping front to back. And then provide Mrs. Valero with pertinent signs and symptoms of infection to report to her healthcare provider. Now, what evaluation strategies would you use? Use open-ended questions to determine the level of learning. So questions that start out with "are you" or "do you" are closed-ended questions. We want to start questions out, "tell me more" or "tell me about." Ask Mrs. Valero to verbalize her understanding of normal urinary function. So a way to ask that would be, "Please tell me your understanding of normal urinary function." Ask Mrs. Valero to verbalize abnormal signs and symptoms to report to her healthcare provider. So instead of "do you know the signs to report," patients will almost always say yes. But instead, you would ask, "Please tell me what are some of the signs and symptoms that you would report to the doctor let's see, I didn't think that out before I started that. What are some of the signs and symptoms that you would report to the doctor that would indicate that you're having a urinary tract infection or urinary problems? Have Mrs. Valero measure water in a container to simulate intake and output measures. And you would want to also make sure you sent her home with a graduated cylinder, or 2 or 3, so that she could measure that. All right, last slide number 50. Following principles of surgical and medical asepsis as indicated when performing catheterizations, handling urine specimens, or helping patients with their toileting needs, we want to make sure that you're following safety guidelines. So to ensure patient safety, communicate clearly with members of the healthcare team, assess and incorporate a patient's priorities of care and preferences, and use the best evidence when making decisions about your patient's care. That also includes assessing the patient's risk for latex allergy or allergies to certain foods, or, for example, allergies to iodine, which is something we use for catheterization. An alternative would be chlorhexidine, which is that pink soap. When performing the skills in this, when you're performing skills such as the nursing skills, the actual psychomotor skills, remember we want to make sure that the patient is safe, and that we also make the patient feel comfortable discussing something as intimate as elimination can be. All right, I hope this Google Hangout worked. If you have any questions, let me know, and I will talk to you later. Thanks.